if you wish to testify and haven't signed up, please do so over there on the sign-in sheet at the side. We've got a couple of people that have given a kind of a maybe answer for testifying, and so I'll need to get clarity on whether those people are testifying before we start, because as you've probably seen from our agenda, we've got a very large agenda, and we can devote, we've kind of talked to the chair, and we've extended the normal talking verbal testimony time from 5 minutes to 30 minutes. So we've got a block of 30 minutes where we can hear testimony, and that's going to include kind of everybody coming up to the table and introducing themselves as well. So we're going to need kind of a final count before we start that to know how much time we can give everybody, and then once we know how much time we have and how many people want to speak, I will have cards that indicates when there's 60 seconds left, 30 seconds left, and time as you're speaking, so that we can give everybody the same amount of time and move on to the next person. So thank you all for coming.
And I just want to update, I know we've received quite a bit of public testimony in writing. If any of you feel that you didn't have enough time to speak today, there's no deadline on giving public testimony. You're welcome to submit additional written testimony to the commission at any time.
And there will be additional opportunities to give testimony as the process continues, both at the Chronic Pain Task Force meeting or meetings. It'll certainly come back to this subcommittee at some point, and then eventually to the full commission. I also just did want to mention, for those that couldn't make it to the meeting today, we do have a webinar of the meeting, so for those that want to follow along with the materials and the presentations that are being given here in the room, you can go to our website and sign up to that webinar. I'll read off just once here, so hopefully if you've got a pen handy, but it's https://attendee.gotowebinar, GOTOWEBINAR.com/RT Robert Trent /704-883-309-249-765-9651. That number again is 704-883-309-249-765-9651. Sorry about the long number.
And that link is posted on our website for those of you who couldn't write fast enough.
If you'll Google Health Evidence Review Commission Oregon, it'll pop up. For some reason, Bing doesn't work. If you try Bing, we don't pop up, but Google is better.
Oh, we're not supposed to endorse things. Google works better for the HERC search.
All right, it's all yours, Erin.
All right, so the Chronic Pain Task Force has met multiple times, and this is their presentation. So again, just to reiterate what Darren was saying, we're not making a decision today. We're basically feeding any thoughts, feedback, ideas back to the task force that's meeting in September. And the earliest any of these changes will be implemented is January 1st, 2020. So just to remind you who's on the task force, we had several pain specialists, a chiropractor, an acupuncturist, physical therapy, primary care, psychologist, pharmacist, patient advocate, addiction specialist. We had kind of a wide swath of the universe of professionals who take care of patients with chronic pain. Many of them also are on the Oregon Pain Management Commission, so they have a long-standing expertise in this area. There was a series of public meetings held. We did literature reviews, looked at expert guidelines, had expert input. So the proposal that the task force came up with is that they feel that we should be adding a new line to the prioritized list that is in the funded area. The line should contain 5 diagnoses. These diagnoses are currently all on an unfunded line that is fibromyalgia and related syndromes, or some wording similar to that. These are effectively sort of generic chronic pain syndrome type diagnoses for people who have sort of widespread pain, without perhaps a more specific diagnosis like knee arthritis or migraine or something. So it's chronic pain syndrome, other chronic pain, and then fibromyalgia, which is the one specific diagnosis. As I noted earlier, the Commission has reviewed fibromyalgia on several occasions and didn't find strong evidence to support coverage for it, so that's why we're having Dr. Jones here to give us a little more insight into sort of how thinking has changed about fibromyalgia. I just wanted to point out that there are no changes proposed to the other types of chronic pain diagnoses. As you all know, there's many types of chronic pain in the funded region. So currently, none of these conditions are covered. They're all below the funding line, so theoretically, they're not getting any services. In reality, as we all know, they're getting primary care office visits because we don't limit those. We want people to see their primary care doctor. And any medications that are not controlled with prior authorizations may be covered for these types of conditions. So the task force strongly felt that there is good evidence that other treatments are effective for these conditions. The non-pharmacologic treatments that they are proposing to add to this line are cognitive behavioral therapy, as well as acceptance and commitment therapy, which is very similar. Acupuncture, just as a quick note, chiropractic services don't actually have evidence for non-spinal pain, so they're not recommending chiropractic for this group of conditions. Health and behavior assessment, PT and OT, pain education, and then if available through a CCO, probably through the flex funds would be yoga, massage, supervised exercise, etc. And then if this line is moved into the funded region, there would also be medications available. So these would include Tylenol and NSAIDs, as well as duloxetine, pregabalin, antidepressants, etc. Some of these may already be available, particularly the antidepressants if the patient has another comorbid condition. So basically, any medication that's FDA approved for chronic non-neuropathic pain. They did add some caveats to medication therapy. They wanted patients to continue active therapy, which could include psychotherapy, to have more than one modality to help sort of globally address their condition and reevaluate their case. So some basic feedback, just any overall feedback that you all have that you want to give the task force. Specifically looking at the diagnoses, one question I know that you all, as well as the HERC, will have is should fibromyalgia be included? Since this final report was done in June, we have been giving this to various stakeholders to give feedback to. There's been a couple of other diagnoses, most importantly is central pain syndrome, G89, should that be included? That's a really rare condition that occurs after stroke. And any other diagnoses that you can think that we didn't include, and then any other treatments or procedures that you feel that we missed. Regarding the new guideline, so we wanted to, the feedback that we've gotten, we probably need to clarify that this is a very limited, specific set of pain conditions. We want to add a new wording to limit, to sort of specify that limit. And then any other kind of concerns about the guideline. And then they also wanted to link their new line to the opioid guideline. As you remember, we created an opioid guideline for the treatment of back conditions when we moved the back and neck conditions above the funding line. We added an opioid guideline. They wanted the same restrictions to the new chronic pain guideline as that we already have for back conditions, which it effectively limits opioids to 90 days after initial injury or surgery. The task force really also, in general, including for back pain, wanted the removal of flare as a reason for short-term opioid prescriptions for all of these conditions, because they feel that there's good evidence that flares are better treated with sort of multimodality treatments. So this is just a reminder to you what the opioid guideline requires in terms of what a patient needs to kind of meet. They basically have to have evidence of functional improvement as well as some risk screening to make sure that there's no red flags while they're with the first 90 days of opioids. Next. And then they the task force felt pretty strongly that long-term opioid therapy has very limited evidence of any benefit and good evidence of harms. They felt that the best evidence for no benefit was in fibromyalgia, and that there is a emerging body of literature that is very new and has very limited evidence of good outcomes from taper programs. We did hear a large number of patient comments as well as outside providers that had concerns with this requirements. And then there's also implementation concerns that we've heard from some of our stakeholders. We received a large volume of public testimony. You all had access to that with the packet, but just in case you had any trouble with the PDF, we apologize. There were some glitches with it made it a little bit more difficult to read, so hopefully you were able to wade through it all. This is a qualitative summary of the types of feedback, so this is not a comprehensive summary of anything, but this is sort of what staff felt are sort of the biggest themes that emerged. There was concern that alternative therapies were not adequate to treat pain or don't work. There were folks who wrote about the benefits that they have received either personally or if they were professionals, they see their patients receiving from long-term opioid therapy in terms of improved function. And there was concerns with involuntary tapers from long-term opioid therapy, reducing function, increasing pain, concerns about increasing rates of suicide or illicit opioid or other drug use. There was folks who wanted to specify that chronic opioid use does not make you an addict. Proposed taper policy they thought was an overreaction to a few bad doctors, patients, illegal drug users, or it would vary by the specific email, but a few bad actor kind of thing. Personal stories of bad experiences with tapers, a feeling that this should be something that it should be decided between a doctor and a patient rather than through payer initiatives, and thought that this discriminated against low-income patients or AP patients.
One of the other themes that I took away was kind of a combination of those two. The involuntary taper creates an adversarial relationship between the doctor and the doctor is trying to comply with the insurance coverage and the patient who they're trying to treat. That was a theme that seemed to come through quite a bit.
So on the original recommendations of non-pharmaceutical interventions, you mentioned that chiropractic is not covered, but they had recommended. And again, the mistake is being made that chiropractic is synonymous with a single modality, spinal manipulation. And so their recommendation was also physical therapy. That's a broad brush. That's not only a profession, but there's a whole cascade of interventions that fall under physical therapy. You might just as well say physical medicine. So passive, active, supervised exercise, therapeutic procedures, neuromuscular education, the modalities, mobilization, manipulation, manual traction, and then all the modalities, interferential, galvanic, yada, 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 all follow under physical therapy. And so to make the statement that chiropractic is not covered is an error. We provide most of all of these things are within our scope and license to provide, not just manipulation. So there needs to be some type of rewording that, in fact, when they say they've done the evidence and physical therapy is effective, well, that's a broad brush. Right? What modalities, what interventions are they speaking of? And so, and most all of those are, I'm certain, are within the scope and licensure of naturopathic physicians as well. So there needs to be some amendment of that language of those recommendations, because we would not want this going through and the connotation of those interventions that fall under physical therapy or physical medicine are only to be provided by a physical therapist.
Is there a way to turn the speaker up? I'm actually having trouble hearing you guys a little bit.
Yeah.
And I know we have a couple people that are hearing impaired.
Okay. We have this problem with our system. If you can't hear it and you turn it up 1 nanomillimeter, then it feeds back, so we'll try and keep that.
You could always talk
Do that
louder.
down.
I mean, that's always an option.
Hold it really close.
Okay.
So
Okay.
I wanted to point out that, G89.0 is already online, you said.
Right. It's already a covered diagnosis, so the concern is whether we should move it. And then it would follow all the limitations of the guideline for this specific. There's no limitations to it currently.
So in the interest of making sure we take advantage of the public participation, I want to make sure that we get first to our presenter. So our goal, so we're doing some of the work that we'll reserve for other meetings, which is the nuances of which codes and which scope and everything else. I think we want to make sure we heard a little bit more about fibromyalgia today and then let the public testimony unfold. So why don't are we ready to move to that?
So can you come up?
Sure.
So, Dr.
You guys turn around so I can stand over there. Would that be possible? I just can't see my slides well enough from over here.
Yeah, you don't have to sit.
Yeah.
As long as we can hear you.
So Dr. Kim Jones has, comes to us with 20 years of team research experience at OHSU and is currently the Dean of Nursing School at Linfield.
And apparently having those credentials don't make you qualified to turn on the microscope.
Microphone?
Do you hear this?
No.
No.
How about now?
No.
Maybe you
Yeah,
borrow
push
a
all the
different-
buttons we have.
How, I mean,
There we
there's
go.
nothing, you guys can't hear anything.
Oh, that was
This one's hot.
hot. It's literally hot. Somebody's been hurt.
There you go.
Yeah. Let's see, we should just go to slideshow mode and hit from beginning. Okay, because this is a much pared down version of what I was going to talk to you guys about. So a contemporary understanding really is that we used to think of pain in these 3 categories that never overlapped. There was nociceptive pain like osteoarthritis, there was neuropathic pain, and you all know what that is, where there's an anatomical lesion. And then there was this new thing called central pain, which would include fibromyalgia and irritable bowel and many back pains and headaches, etc. But what we've really learned in the last decade is that over time, most people don't stay in their pain category. These become blurred. Central changes occur in all of these pain states. There's now documentation that even people with osteoarthritis, which is a traditional nociceptive pain state, have central changes. So the idea is that there's not one kind of pain and that it changes over time. And it moves toward these areas that we see in fibromyalgia where there's central dysregulation. And we can see central dysregulation in fibromyalgia as a functional lesion as opposed to an anatomical lesion, and we can see it reliably on a number of neuroimaging techniques, PET, SCAT, fMRI, etc. So you guys are familiar with these. These are not new drugs. These are the FDA-indicated drugs that we have for fibromyalgia right now. Go ahead. And you're probably not also unfamiliar with the fact that if you're lucky, 50% of people will get 30% better. Not great, but it's not unusual for a first generation of drugs. Okay, so we have other drugs that we use in fibromyalgia that have an evidence base. So let's go on to that. Go ahead. So this is the category where we really have strong evidence for fibromyalgia, and it's the alpha-2 delta ligands like pregabalin and gabapentin, the dual reuptake inhibitors like the SNRIs. So one of the low-hanging fruit is to help transition people from SSRIs to SNRIs. Tricyclics and antidepressant agents, particularly at night for sleep. Sodium oxybate, really nice phase 3 trials, multi-center. It's on the market for narcolepsy and cataplexy, but not for fibromyalgia, but the studies were done in fibromyalgia. So if we move on to moderate evidence, I want to draw your eye to 2 of those drugs. The first one being tramadol, with or without acetaminophen. Those studies were done at OHSU with people with fibromyalgia. When Ortho took it to the FDA, there was a decision that because nothing with fibromyalgia had gone through yet, that maybe we should not get it indicated for fibromyalgia. We should look for it indicated for moderate to severe pain. And you know that most of the life of this drug, it was not a scheduled drug. That's a more recent change that this was now a scheduled drug. The other one I would draw your eye to is this low-dose naltrexone. Only about 3 publications in this area, but very safe. not terribly expensive way to really work on the mu-opioid system that's not an opioid itself. And then the last category, we have negative evidence for NSAIDs. We really have no RCTs for opioids. So anytime we hear about opioids not working in fibromyalgia, it's not based on RCT data. It's based on animal models. It's based on other sorts of levels of evidence, but it's not based on RCTs. Let's move on. So where are we with the non-pharmacologic treatments? We have a preponderance evidence for 4 things: exercise, hydrotherapy, patient education, and a variety of cognitive behavioral techniques. And we have mounting evidence in acupuncture, diet, and mindfulness. And then we have a lot of piqued interest in herbs and cannabinoids. And another day we can talk about cannabinoids if you want, but right now 2 studies and they're with the synthetics, and so it's not that level of evidence that we're hoping we'll have in a couple more years. So this is the most important thing, I think. We now have multiple stakeholders in many countries. This is a 2017 guideline statement saying the diagnosis of fibromyalgia should be explicitly communicated to the affected individual so that you can start with shared decision-making and a stepwise approach to treatment. So the problem is if clinicians can't say this is the diagnosis you have, then patients continue to cycle through the system looking for, well, maybe it's this zebra condition, or maybe it's this unusual thing, and get a terribly high medical bill and lots of unusual and unnecessary treatments, including surgeries that are not helpful. So being able to say fibromyalgia when a person has fibromyalgia is really important. Let's go ahead. Multimodal therapy is the norm. At a minimum, some sort of exercise and some sort of cognitive behavioral strategy, knowing that medications would be on board. So what about exercise? We have almost 300 trials now in exercise. As long as it's appropriately modified, this is really a mainstay treatment for fibromyalgia, not the only treatment, one of those 4 main treatments. Reduces lots of problems of fibromyalgia, but importantly, see that it's this mixed type exercise that's strength, flexibility, aerobic together, or strength training alone is really found to be effective now in fibromyalgia. Balneotherapy is something the literature is replete with this, mostly from other countries, because this is a standard way to treat chronic pain and fibromyalgia in Europe and the Middle East and other places. Keep going here. It builds natural resistance to muscle just to move through the water. The buoyancy may actually reduce nociception by acting on both thermal and mechanoreceptors, and it decreases load on lower extremities. So this is something that, however we can help patients find access to, is really quite an effective treatment. Let's move on. So what improves in these land-based trials? The first one would be physical function or physical fitness, and at a decent effect size. What doesn't improve is sleep, so we really are still in the trenches about what to do about sleep and fibromyalgia. That's why we use CBT and medications in that area. What helps with exercise but isn't sustained after the trial is pain. So what's really emerging, go ahead, for sleep and pain are these mindful movement interventions, Qigong, yoga with mindfulness, Tai Chi, and land or water. But you can see these are very modified. Go backwards one. So this person is, on a chair. So she's not doing yoga that, you might just walk into any facility and see a pretzel person doing yoga. So it's very modified for fibromyalgia. But it's really helping pain, fatigue, sleep, and physical function. Cognitive behavioral therapies, we've had this since the 80s, incredibly helpful. But then in the mid-2000s, like 2005, we really saw this preponderance of acceptance-based therapies come online, and in many places outperforming standard CBT. So let's move on. And this is why I think, so if we did standard CBT,
Speak up a little bit more, please.
Yeah.
The mic went out.
Really
Oh, the mic went out.
Yeah.
If you put it down, something
Really
is
close
just,
to your mouth.
This is really close.
Yeah.
There you go.
Yeah.
Breathe on it.
I'm feeling very connected with my friend, the microphone.
I think one thing that can help with feedback is if the rest of us turn our mics to standby mode. That'll make it less likely to feedback.
Oh, and
So
then,
it's off?
can that make
Yeah,
it so
stand by.
that we can turn up the volume a little? I'm sorry, I'm
it's
just
really
really
hard to
difficult
hear you guys still. I mean, even if you could just like project a little bit, that would be awesome, guys.
Okay, how's this for projecting?
You gotta hold it.
Got it really close?
Yeah.
So traditional CBT really looked at anxiety, depression, fear, catastrophic thinking, and tried to turn those things around. But in the last decade, we have a lot of neuroimaging data about these techniques, these things that promote resilience and protective factors, social support, active coping, acceptance. So people, when they're allowed to know this is the diagnosis you have and do therapies that help you accept that this diagnosis is what you had, it helps stop, it doesn't just change your brain, which we see from imaging studies, it changes that cycling through the system where people are looking for more answers and more treatments, okay? Let's go on. So summary, here's where we have strong evidence: Tai Chi, Qigong, yoga with mindfulness, hydrotherapy, and acupuncture, which is almost in that strong evidence category. Move on. And this is where we have consistently small, positive, but safe therapies: EMG feedback, weight reduction with specific diets, manual therapies that didn't include manipulation, but Vern, they were exactly what you were talking about with all those other things that chiropractic practitioners can do for our patients. Massage, relaxation, biofeedback, mindfulness, hypnosis, guided imagery. And then what's not effective in the literature, herbs, nutraceuticals, Reiki, homeopathy, magnetic field, laser, and phytotherapy. So these don't yet have support in the literature. So then my last slide in summary is that chronic pain may initially be nociceptive, neuropathic, or central, but over time CNS dysregulation occurs in many people, and many people more accurately have this complex chronic pain syndrome rather than a single diagnosis. Most people do not keep their original diagnosis the rest of their life, but move into central states. So for treatment strategies, you need to provide the patient with the actual diagnosis they have and do that early. You need to normalize multimodal therapy. We need to use medications. We need to make exercise available to people. And enlist practitioners of cognitive behavioral and acceptance therapies early rather than late, and don't require that they have anxiety or depression in order to get to these therapies. And then we need to decide on what's really our best functional measure so that over time we're not looking at pain as the fifth vital sign, we're looking at measures of functionality. Thank you.
Any questions? You have a question?
I just took this on the running and pestered Kevin for just a second, but could you just go a little bit more into what a functional lesion is?
Yeah, so in neuropathic pain, you have a lesion in either in the peripheral nervous system, right, or you have a lesion in the central nervous system, like a thalamic pain or MS pain or a spinal cord injury pain. That would be an anatomic lesion. In the central world, what we've seen is that on a variety of now neuroimaging studies, there are predictable areas where blood flow is abnormal, where neuroanatomy is abnormal, and it acts as a lesion just like an anatomical lesion would. So that's, Dan Claw has written about it, Rick Gracely has written about it. There's about 4 really good papers now. I'd be happy to forward you some of those as you want. Is this idea that we have a functional lesion occurring in the central nerve. Well, we can't say the whole central nervous system because we can't image the spinal cord the same way we can the brain yet. But in the brain, and where the brain is active.
I had a question just about how we make the diagnosis of fibromyalgia. So in my 20-year career, in the old days, it was a garbage can. Call it fibromyalgia if you didn't know what else to call it. And then it turned into this thing that was so specific there was maybe 5 doctors in all of Portland who could actually make the diagnosis. And so are we clear about how to really call fibromyalgia as opposed to a chronic pain syndrome, otherwise unspecified?
Okay. So this is the question of lumpers versus splitters, right? So we were being a splitter back in the 1990s when we said you had to have this specific kind of widespread pain and these requisite tender points that many people couldn't find, right? And so we went toward then this broader criteria, which was really patient self-report of a variety of signs and symptoms or symptoms. Since that time, we've been concerned about not